So it gives me great pleasure today to welcome Britt Hove, who's a senior physiotherapist at the University Hospital in Oslo. She is doing a fantastic and really interesting PhD in mechanical insufflation exsufflation and patients with neuromuscular disease, and has been particularly focusing around not only the use but the settings of this. And she's going to give us some top tips today about how to apply mechanical insufflation exsufflation in patients with neuromuscular disease. She's also associated with the National Advisory Unit of Long-Term Mechanical Ventilation. Britt, I would be really grateful if you would just explain to us the anatomical and the physiological differences from an infant to adulthood.
Thank you. It's a long time since we saw the children as small versions of adults. Their anatomy and physiology develops from birth and during childhood. So in short, and focusing on the differences most important for the mechanical insufflation exsufflation, we can begin where the air enters the airways, namely the upper airways. In children, the tongue are relatively larger. The nasopharynx is smaller with more adenoid tissue and larger tonsils. When we come further down, we can see that the epiglottis is higher and floppier, and it's omega-shaped. Larynx is more anterior and superior positioned, and it's funnel-shaped with the narrowest point at cricoid cartilage. This means that the airway are narrower, they are more predisposed to obstruct, and they are softer, that makes them more collapsible. Then going further down, the lower airways, the trachea, is also narrower with a higher resistance, or with the smaller airways together. Cartilage are developing, so it's soft in the beginning and stabilized during the years. And the lungs develops during the childhood, and it has longer volumes with a smaller, lower total lung volume, lower tidal volumes, and a lower functional residual capacity. And the thorax, in small children, the costa is horizontal positioned, and they make out a smaller share of the body, with the diaphragm more horizontal, and the intercostal muscle are developing. This thorax in the small child has a high compliance with a reduced elastic recoils. This position of the thorax makes the children less able to increase the lung volumes, but they have a faster natural respiratory rate. And when something occurs, they increase the rate instead of the volumes. So in total, the airway is more exposed to airway collapse and obstruction, and the changes occurs rapidly. I think it's important to remember the normal respiratory rate for a child, because this is important when we start to talk about settings later. In a newborn child, the respiratory rate can be as high as 60 breaths per minute.
Britt, that's wonderful. I think it's really important that people understand the differences between infants, children, and adults, because they have the potential to go off so much quicker than an adult patient. If you could explain to me now what initiation criteria you would use for mechanical insufflation exsufflation in infants and children, that would be fantastic.
It's important to remember that the mechanical insufflation exsufflation is a tool to assist the cough. As you know this paper very well, Michelle, we use this when we want to assist the insufflation and exsufflation to assist a weak cough. And then we could use this figure made by the same group, but we can't use these normal values. As long as the child is old enough, maybe from 4 to 6 years old, we can do an assessment of lung function and cough ability, and we prefer to do it in the lab in the hospital, that we can use the digital equipment. Then we know that children around 12 years of age should have a vital capacity about 1.1 liters or a peak of flow above 160 liters per minute, or they would be exposed to severe chest infections, and they should be introduced to assisted coughing techniques. In children, they have very low volumes, so we prefer, as I said, to use the digital meters if available, but you could also use an analog scale, but then use one with the pediatric scale. Otherwise, you won't be able to see proper. Some children have problems to perform this maneuver of coughing into a device, so it's difficult to perform. Then we could use the peak expiratory flow as a substitute. They are similar. And then in this 160 liters per minute, around 12 years of age, we can't use this in smaller children because their normal values are lower. So then we use this material from Bianchi, presented percentiles of cough ability. This one is on boys, and then you can see how the peak cough flow increases with age. Then one way to decide if they need cough support or a mechanical insufflation exsufflation device would be to take the 5th percentile or the centile, and then 50% below that would say they have a weak cough. Sometimes if they have a diagnosis where we know it's going to be problems, and we think they will eventually soon come to that we would choose a device, we can start the initiation when they fall below the 5th percentile, when they are below the normal values. From a paper we presented this January this year, we saw that the device was used mostly in spinal muscular atrophy, where 1 of 3 children had a device to cough. And also in muscle disorders, Duchenne, other dystrophies, myopathies, the prevalence of mechanical insufflation exsufflation device was high. But surprisingly, as much as 1 of 3 of the children had a condition in the central nervous system, a degenerative condition, or even cerebral palsy. So it's not only the neuromuscular, the peripheral weakness, but it also could also be appropriate in other conditions. But it's important to say that this is not proof of effect. It's just a description of how it is in Norway today. I forgot to say the prevalence overall is 6 of 1,000 children with a neurological disease have a device to assist the cough. Sometimes you can't measure the peak of flow, you can't measure the vital capacity. Then you just have to use if they have a disorder where they have a problem with weak cough, you can hear they are weak in cough. If they have a history of recurrent or prolonged respiratory tract infections, we would consider mechanical insufflation as a treatment for these children to support the weak cough.
Thank you, Britt. That's really great. I always forget to point out measuring vital capacity as a % predicted in children. I think from the adult perspective, we get so focused on peak cough flow that we forget that there are other surrogate measures. And you are so right, the neurological children also do benefit, despite the fact that there is a lack of an evidence base, and we saw that we were using it in that group too. We've got an idea of what patients we should be using mechanical insufflation exsufflation in and when, but I'd really like to know a little bit more about how you would start mechanical insufflation exsufflation in infants and children.
Yeah, I think it's very important. First, when possible, when the initiation is elective, I would use time to assure that the parent or caregiver that accompanies the child understand why we do this and that they are comfortable with us trying it. The child senses if the caregiver have resistance, and if the child meets the eyes of a calm and confident caregiver, they will be more calm and comfortable themselves. It's so many times that I have, it's not possible to proceed and have success if you don't take the father and explain and maybe make the father try, and then before we can go further. I find this very important. In the adults, you can explain the rationale, but in children, they are not maybe able to understand why. So they need the children to comfort them. Then I will use the treatment on a teddy bear with a mask on the knee or even on the chest to familiarize with the sound, and maybe we can hear what you call it, blow dry the hair of the child, so they get used to the sound and the flow and the mask. Then I think it's very important to pay close attention to the mask fit, as by my experience, leakage to the eyes is the thing that the child finds most uncomfortable. We would like to have a nice mask fit, and then we use a firm grip to avoid leakage to the eyes. Just flushing the mask in the face is no good, but holding it firm. But we have to avoid to push the jaw backwards, because that closes the soft airway. I would initiate the treatment in any position where the child feels most comfortable, but it's important to know that the airway of the small child is open with the neck in a neutral position. And with a child with a big back head, and if we put a pillow underneath, we could even close the airway more. So sometimes it's a good thing to put a pillow below the shoulder instead of under the head. So nice mask fit without pushing the jaw backwards and the neck in a neutral position, then we are ready to go. As soon as they are able to understand it, I will use the a triggering on the insufflation, so I can say, okay, now you can decide when the air is coming. Then I use this, also a paper from you, Michelle. Then we try it. We start with the pressures from the non-invasive ventilation, or 5 more, as you describe here, and we start maybe on 15 centimeters of water, and we work on the insufflation. I think when we have achieved insufflation, then the exsufflation goes better. I will use most time on this one.
Britt, we obviously have a very similar practice. I'm just interested to know a little bit about triggering. Do you ever have any problems with your children or infants actually triggering the device? And if you do, what would you do then?
Yeah, sometimes it can be a problem when they are very weak. I can't make the machine to trigger. Then I would manipulate on the chest or maybe on the mask to get it starting. And also it's a delay, so they have such a fast rate, so the machine is not able to follow them at every breath. But I think that's okay. Then they have a cough, and then they have a smaller breath without triggering, and then they get a cough again. But yeah, it might be a problem. It's important to be aware of it. And sometimes we also have then, if the children are very unstable, if they suddenly go into mucus plugging or something that they don't trigger at all, then I will have a acute program set, so I inform the children, go there if the child is very weak. So then you drop the triggering to be safe.
That's a great tip, thank you. Let's just talk a little bit more, if you don't mind, about the settings in infants and children.
Yeah, I would love to. Here is my where I will try to make it simple for you. I will try. I think what we are looking for is this nice rise of the thorax, bilateral on both sides, is a good feeling. And then many of the people not working very much with neuromuscular disorders, they are very afraid of the volumes. So then you could add, we want to use safe volumes to avoid adverse events. And we also know that maybe you cough the most efficient when you have submaximal volume, so it's no point to overfill the lungs. And then you need this efficient soundable movement of secretion. We are looking for that. And at least long term, we need the settings to be comfortable, so they will be used by the children. So otherwise the children won't use them. So we surveyed the settings in use in Europe, and we saw that a lot of children were using preset settings with 40 centimeters of water in and out, and maybe 2 seconds in and out. And it's difficult to see that how a small child with a respiratory rate of 60 should use 6 seconds on a respiratory cycle, leaving them with a respiratory rate of 10. But we saw this, and we saw that the settings they varied great, but they increased with age. We know from a lung model study from before, they had a healthy child, 1-year-old child with healthy lungs, but they had tracheostomy, and then they used mechanical insufflation, exsufflation, and found that you need more than insufflation time of longer than 1 second, and the increasing the exsufflation time doesn't alter the maximal expiratory flow. The pressures, both the insufflation and exsufflation pressure is important, but the greater exsufflation pressure had more substantial impact. So we also used a lung model to study settings. We connected this to this simulator, simulating a 1-year-old child with neuromuscular condition and a lung volume of 500 milliliters, as a 10-kilo 1-year-old child would have. And then we tested 120 different setting combinations. So what we found was first on the maximal expiratory flow. I don't show this, but we can see that increasing the expiratory time above half a second did not impact the expiratory flow. So all the flow diminishes before half a second is gone. So that's not important for efficiency, maybe for comfort, but not for efficiency. And then we had the other time settings. We could see that the half a second in was the same as in the paper from Spriegel, that achieved lower expiratory flows. But if you used 1 second or 1.5 or 2 seconds, as the blue and purple lines show, you can have a similar increase in pico flow with the pressures. And then we go to the pressures. You have the insufflation pressure on the x-axis, and in the panels you have the expiratory pressure. You can see if you use expiratory pressure of -40 or -50, this impact of the insufflation pressures levels off. It's not, you don't get higher expiratory flow with increasing the pressures above maybe 20, 30 or 20, 25 centimeters of water. And then if you looked at the lung volume, if we want to listen and answer the people afraid of the lung volume, then we can see the same, that half a second insufflation is not enough. But if you use the 1 second or more, you can see that this volume also levels off, but many of the pressures are receiving a volume above 95% of total lung capacity. So if you want to stay under that, you should use lower insufflation pressures than exsufflation pressures. Just to prepare for this talk with you, Michelle, I just put this slide on, and then I put you don't have a scale on the y-axis because it's the flow and the volume, but then you can see that the expiratory flow levels off before the inspiratory volume. So by increasing the inspiratory pressure above, dependent of the expiratory pressure, but from 25 maybe centimeters of water, you would just achieve higher volumes. So we put this together, and then we said in this graph, we don't have, as I said, 1 second exsufflation because it was exactly the same table, but we have a time settings of half, 1 second, 1.5, 2 seconds on the top, and then we have the inspiratory, expiratory pressures going downwards. We can see that using short time, low pressures, you don't reach the quality criteria that we set. And if you use long times and high pressures, you will get a lot of volume and even above the total lung capacity. But here we suggest that you could maybe use a lower insufflation pressure and a high exsufflation pressure. And dependent of comfort, you can use, and state, you can use long inspiratory time, short expiratory time, or shorter, faster rates. It's important to mention that this lung model in the box don't have any larynx. So it's a stable airway. So we don't know anything about collapsibility. So that has to be studied. We have to verify that this table is, but maybe it can be a guide.
I think it's a fantastic guide, Britt, and really reinforces what I've been doing clinically, which is a nice insufflation pressure, but not so much that you feel like you're blowing the child up, and always having a greater exsufflation pressure. And for me, it was when you were talking about the sound of the sputum moving, that rattle you get in the tubing, and you get, as physiotherapists, very excited. That clinically is reinforcing my practice. So I'm really glad that you have done this work, because I think it is so important. I also think it's really interesting that you have looked at the expiratory flow, and having a short time is sufficient. I think one of the things that people possibly thought was that when we cough an awful lot. But you're right that it's only the first part of the cough that is the part that moves the sputum, rather than taking people right down to their collapsing volumes. And I think that that's also important for patient comfort, because when we do a long exsufflation, you can see, particularly in children, that they're in their closing volume and they can't get that breath back in. So I think you've done some fantastic work to help us with regards to the settings in children.
That's good, thank you. It's two conditions where I will choose to have a long exsufflation time. It's if I working with a child to play with the device, that okay, now the exsufflation comes, you must cough with the device when we teach this or learn this. And also sometimes we have children, they shut down, and then I see if by prolonging the exsufflation time they would open during the because the exsufflation flow then is rapid.
That's a really good point. I hadn't thought of that.
So we have seen that sometimes that when they close and then we prolong the exsufflation time, they will eventually cough or open and cough. But it's a comfort. Yeah, you have to always look at the child and the comfort of the child.
So we've talked a little bit about, just when we were talking about titrating settings, about how we would know whether they're working. But I was wondering if you could give us a little bit more information on the evaluation of treatment and how you know it's effective.
Yeah, I think it's most important what you said, that we hear this audible movement and the rattle and the secretion movement. But it's important to know that it happens rapid. It's done faster. Sometimes we need to auscultate, or the chest, or even on the larynx to have an impression of what happens. And if we get mucus into the mouth, that's good that we can actually see it by suctioning. That would be nice. Otherwise, we would also look at your paper again. Does how is the insufflation filling the lungs? Do we see a good rise and fall of the abdomen? And then on the exsufflation, we could hear the cough ability increase if the secretion is coming out, and also we can use the device to assess how the cough flow. And then it's important to know that with closed airway, you would have some value. You can, with closed airway, you can move some air into the device, but then and in small children, maybe use the pico flow values from Bianchi as a guide, because you don't expect 270 liters per minute. You will have lower values.
Thanks, Britt, for pointing out that when the airway is closed, that you will still see a change in cough peak flow on the device. And that is a key point, because sometimes we think artificially we're improving things by increasing the exsufflation pressure still further, and that will by default increase the expiratory flow measured on the device, but the airway is closed. So you're right, it is about listening, looking at the patient, and taking the whole package. I find as well, in infants it's quite hard, but in children you can also hear the audibility improve too, and you suddenly just think, yes, that's the right pressure. What are your thoughts on that?
It's absolutely. It's the audible. If you hear something, that's the okay, we are there. Sometimes the parent, you have to remind them that it happens very fast. So you don't expect any long rattle as in a adolescent, for example, but I agree. If you hear it, then it's good.
Perfect. So, Britt, you've told us beautifully about how you would set patients up and get the optimal settings, but looking at things more long term, how would you follow up your patients? And could you give us some advice on when you find in your experience you've needed to adjust their settings?
When we start the treatment, I will have a close contact with them. They will come back to the clinic to increase the pressures mostly, or we can sometimes we achieve everything in one day and then we say, okay, you can call us, or we call them. Sometimes we use the preset programs or the profiles and adjust mostly the insufflation pressure up, and then they can change the preset program to come up in pressure. Then when they are set on the treatment, the children, they are on long-term mechanical ventilation. We follow the protocol on every 3rd or 6th month or even every year to see if everything is okay. Mostly it's small children, more frequent than the adolescent, not so often. If they we can see them both on the outpatient clinic or during a sleep study in the clinic. It's different. To look at when would I adjust the settings. Sometimes a child gets sick, get the respiratory tract infections. It's not able to be at home anymore, so they come to the hospital. Then we would have a change. They have a faster respiratory rate, and the airway would probably be narrower from mucus and edema in the airways. So then I would suggest, with the faster rate and the higher resistance, maybe should you try a shorter duration, both on inspiratory and expiratory, and a higher inspiratory or expiratory pressure. But be aware of this lung model study that they didn't have any collapsible airways, so you have to look and see if that works. Sometimes if they are not able to turn the condition, then they get intubated. You would have a higher resistance in the artificial airways. I would increase the pressures even more, because we know the resistance from the tubing with the impact what is coming down to the lungs. The next condition I would suggest to look at is if you have instability in the airways, if you feel it collapses. If they have dysphagia, they can't swallow, it's dysfunction in the larynx, then I would suggest to use this approach described in ALS and recently also described in a clinical case on a small child with the SMA, where they could see that with insufflation pressures of 35 centimeters of water, the larynx collapsed on insufflation, also shown in the flow curve. But when they used a lower insufflation pressure of 25, they were able to maintain the larynx stable, and the flow, inspiratory flow, showed that the airway was open during the insufflation. So then I would suggest to have a lower inspiratory pressure, but keep the expiratory pressure, have a long inspiratory time, and then use a long rise time. The next condition would be if the child is in a very preventive state. They have their machine for mechanical insufflation for long-term use at home, but they don't have any mucus. So the main goal would be that they should prevent their skill to use it for worse days, or they would keep the range of motion in their thorax. Then maybe I would focus on insufflation and then maybe use a higher time, so they stretch the thorax, but sometimes I would even drop the exsufflation. This last thing is with increasing age, then they would have a respiratory rate that lowers, the airway and lungs get larger, and the thorax get less compliant. It gets stiff. Then I would increase, actually all settings. I would increase the timings, and I would increase the inspiratory and expiratory pressure. Maybe the expiratory pressure is high, still high, but yeah.
Britt, I think that your tip for using it to maintain range of movement is important. I saw a fair few patients who I tried to encourage to use it on a daily basis to maintain range of movement, a little bit like cleaning your teeth, and found that as they grow, those patients experience less chest wall rigidity as a fact of that they were having a regular chest wall stretch. And I just wondered what your opinion on that is.
Yeah, I agree. I also recommend not my parents, but children, my patients, to use the treatment every day to maintain the skill to do the treatment, but also to try to impact the range of motion in the thorax. And then I say they should do it before they start to stiffen. We know that happens. And then we don't know how much, but we used to say maybe twice a day. I know it's a paper from German group that they used the device for 10 minutes a day, and they were able to show an fall in how the vital capacity declined. So I totally agree.
I often get questions with regards to whether mechanical insufflation exsufflation should be stopped in the post-operative period. What are your thoughts on that?
I think it's important to remember that these children, they are dependent of their their coughing support, and in the postoperative period, it's more important than ever to actually clean their lungs. And we know from a small paper that they measured the pressures and saw that cough made of own effort produced higher abdominal pressure than the MIE device. To avoid post-operative complications, it's very important that these children can remain with their treatment during this period.
Brett, I'd like to thank you so much for spending the time with us today on our Education by Briaz series looking at paediatrics. Your talk today and your advice with regards to mechanical insufflation and exsufflation in children, I'm sure will be invaluable for the people watching it. Thank you.
Thank you for asking me, Michelle. You have been a great inspiration for my work, as you could see on the slides. And yeah, I'm very happy if some of my work could be of any use to the children and parent and yeah, the professionals out there. Thank you.
It's brilliant. Thank you so much.